there's this stuff that'll come up. Okay, so we'll get started then. Catherine's gonna present on a paper that was recently published that I'm very curious about. If you can share it, I don't know if you're in the meeting, I can pull it, if not. Okay, yep, she put the. Okay, so we'll get started then. Catherine's gonna present, so just put it in. On a paper that. That's a silly thing that it would even let the audio play. About alcohol use disorder among healthcare professionals. A review paper that I'm very curious about. Especially as it highlights some stuff about impact of possible impact of COVID. In that, I think a lot of us have some anecdotal data just about those two topics. Alcohol use related to COVID and alcohol use among healthcare professionals. But yeah, if you could walk us through it, let's turn it over to Catherine Staten.
Sure. Thank you. So this is a paper that they contacted me to give my input because of the alcohol use disorder and perspectives for healthcare workers. This is turned into a perspective paper and a call to action. It's published in Health Promotion International. The first author is Hannah, who I actually just met for the first time when I went to Inebria in November in Barcelona. I don't remember what city I was in. Part of the reason why this was really interesting is this is her thesis. And she pulled this all together, and all I did was give some feedback here and there. And this was a really cool paper. As we start to think about alcohol use disorder, there are some very high risk groups. Strangely enough, alcohol amongst healthcare professionals is not thought of as a high risk group, but it is a high risk group. And so there it is. I'll turn my video on so you can see me.
Oh, isn't that nice?
And so this paper essentially walks through a little bit about the background of alcohol and then goes right into a systematic review. Part of what they wanted to do is really understand, specifically in low middle income countries, but also elsewhere, what the prevalence of alcohol use disorder was amongst healthcare workers. Now, why is this impactful? One, healthcare workers have a really stressful job, as you heard. I almost got bed bugs this weekend. Lots of stress, okay? Lots of stress. Similarly, we just went through a pandemic. During the pandemic, we were essential workers where you didn't have a choice, you had to go to work. Many people left the healthcare industry because of that. The amount of stress that is within the healthcare workers in general is pretty high. It is a very challenging place to work at times. And we are horrible patients. I say we because it is true. And so part of what we're trying to take a look at here is really understand what is the risk to not only this group as an occupational group, but also then the patients that we serve by those who are suffering from alcohol use disorder and not really having a voice or having an understanding of that prevalence. So they took a look at, should I join the audio?
No, you don't have to do anything. Just like tell it okay or cancel.
It says join audio or show again later.
Don't show the audio for sure.
So they took a look in normal systematic review fashion and went through PubMed, Scopus, and Africa-wide. They removed duplicates, found abstracts, and searched abstracts, went through eligibility criteria, and then down to identifying of the papers. Wow, that's gonna be hard. Maybe I should turn it.
You can rotate it. There's a little circle. There's a thing at the bottom right there. Yep.
Look at that. So part of the cool part about this is they were able to separate a lot of the studies by where they're representing. So if you see a lot of the countries that are here, almost all of them are high income countries. There's very few low income countries that are represented here. And that's the first big red flag for me. We need to understand all of our population risk factors. I do also want to call attention to some of these familiar names and some of our partners in other locations of the world, like Dr. Jaguga, who's in Kenya, and get people to realize that a lot of the data might be coming from high income countries, but the status and the culture of healthcare workers in other places really lends us to say we have to take a look at this elsewhere. Okay, so this is what some of the studies looked at. Many of them were cross-sectional design and the study sample was really high. Some of them did and some of them did not assess alcohol use. If it wasn't alcohol use, it was then alcohol use disorder, and they used different screening tools. As you know, the audit is a 10-question scale that takes a look at amount and consequences and long-term consequences. So binge drinking and or injury to yourself or others. The audit itself is the largest of them. It's 10 questions long. The audit C just focuses on the consumption. So how much and how often do you drink? And then it goes back and forth between the audit, and audit 10 is all 10. I don't understand why there's a difference between audit and audit 10. That doesn't make any sense to me.
Cool.
Cage is 4 questions. Has someone advised you to cut down? Something about
I don't have it
I don't
memorized.
remember. Something about G, which is, are you guilty when you're drinking too much? And then do you need an eye opener, which is like a drink in the morning so you don't have the shakes. This is a very clinical thing that we use to identify people who might have severe alcohol use disorder. So I don't really recommend it for a screener. This means like you need alcohol so you don't shake. That's probably pretty advanced alcohol use disorder. So as you can tell, some of these screening tools are different. And the locations are high income. So they also looked at pre-COVID and COVID components. The DUDIT is like the audit, except it also has drugs. It's a really strange name. I can't stop laughing when I say it. Please note that they took a look at doctors, nurses, psychiatrists. Some of the programs were more diverse in terms of the healthcare workers that they assessed, which was great. Some more focused, like just specifically nurses or surgeons or physicians. So getting to the meat of a lot of the work here. As you can tell, there's a lot of them. I really like the fact that they found a lot of different studies from all over. Oh, here it is. Cut down annoyance by criticism, guilty feelings or eye openers. I might have to turn it back. So overall, the studies that they found, a lot of times, 80% of the time it occurred in a high income country. Low and middle income countries, only 20% of the time. And of course, that we know a majority of the world lives in low and middle income countries. Most of the studies were cross-sectional design. Most of the focus was on physicians and not on others. And most of them were pre-COVID, but there were some almost 30% post-COVID components.
It's a lot considering the time span.
Correct. So this is really cool. Let's see if I can make it a little bit smaller so we can get most of it on the page.
I'm sure the authors had the same question for this.
Oh, yeah.
Well, you could present maybe it's in chunks, right? So one's just audit.
Yeah, the top one is audit. So as you take a look at this, this is the meta summary where it brings together the prevalence of alcohol use disorder by whatever screening tool is here and the papers that are there. So this is the pooled prevalence because since it's using the same screening tool, they brought together all of the different data. So this is the pooled prevalence here. And then this is the effect, essentially meaning what the number is and what the distribution is for this individual study. And then this is the pooled effect. So a samples 15 is the proportion with a range from almost 11 to 19. As you take a look at it, depending on the screening tool used, you'll have a different pooled prevalence. Part of the challenge here is that these aren't also separated by location, because I think that we would see a far different locational difference by all of these, but it is a non-insignificant amount. Alcohol use disorder rates are not 15% of your general population, by the way. We're talking more like 8, maybe 10%. So a 15% alcohol use disorder prevalence is pretty high, far higher than our general population. When you look at the consumption, so this is amount and how frequent you have drinks, we're talking almost 30% prevalence from a 21.7 to almost a 35 as a summative prevalence there for this subgroup. And then Cage, I don't know what's going on with this one group that has almost 80%. That's kind of terrifying. I definitely don't want to work there, nor be a patient there. But this prevalence is almost 25%. As I said, that those are 4 criteria of which they counted 2 of the 4. Cut down, annoyance by alcohol, guilty when you're drinking too much, and then an eye opener in the morning. That's terrifying that 25% of the population who takes care of other people are screening positive for alcohol use disorder by those criteria. So looking at this, and the point of this was really to focus on the fact that there are a significantly high prevalence and it is a very high risk group. The next thing we did was, because COVID is such an impactor on this population, when we looked at it at the whole, we noticed that there was a lot of studies that were done after COVID and before COVID. And so we wanted to see if COVID had a difference in terms of the amount of alcohol use disorder during that period. So looking at the COVID time period and the pre-COVID period, so all of these studies were together in the prior numbers, we see a dramatic difference of 28% in the COVID time period for that summative prevalence, and 11.5 average prevalence in the pre-COVID time period. Again, take a look at the locations. The majority / all -1 is from a high income country. And these dates are 21, 22, 23. And so the prevalence in 23 obviously is going to be very different by that 20 and 21 or 21 and 22. Remembering again, this is when they were published, not specifically when the data was collected. And so there might be a little bit of lag time in terms of the publications date and when the data was happening, in terms of the phases of COVID and the impact on the healthcare workers. So I think it's pretty obvious that we have two problems going on here. One, we have a very sick alcohol use disorder using population or work population. And then two, with the COVID pandemic, this high risk group became even more at risk for self-treatment with alcohol during this stressful time period, which led to higher rates of alcohol use disorder screening. This one looked specifically with the COVID tool, the Audit C tool, which was the consumption tool, and pre-COVID versus post-COVID. Remember, as you're looking at different tools, you might see different components of risk. This is purely consumption from this tool, and they actually were similar in terms of their summative means. Again, only South Africa represented in one study. And looking at the time periods, you have a more appropriate time period around the COVID issues, right? Published in 2020, 2021. Again, this doesn't talk about when the data was collected. It was just when they were published. And then finally, this is using the audit tool in general. And with the audit tool, we see a comparison of the doctors versus the others, like non-doctors. Again, all from high income countries. This Brooks et al. Does have some data from South Africa.
There's Nigeria and Brazil.
Yeah, there's one with Nigeria, one Brazil. So we have actually other healthcare workers are screening a little bit higher. I would be a little bit concerned about those numbers because of the heterogeneity of that group on the bottom. I would also be concerned because of the heterogeneity of other healthcare workers. Like, what does that mean? So I was arguing that we don't do a summative analysis of this subgroup because they are so heterogeneous, not only in numbers, but in concept. But they wanted something to be able to compare the physician group only to. So this is what we did. So that being said, the bottom lines are, this was a very interesting paper. We took a look at all of the different tools that are used. And one of the things that we suggested is that there are too many different tools that are available to be able to be used. And we need to standardize our tools in alcohol use disorder. Two, it was healthcare workers are a very at-risk group with physicians leading the way. And then any increased stress within the environment of the healthcare worker system is going to lead to other mental health strain and potentially alcohol use disorder amongst this population. And so they warrant a little bit more focus. So this is the same thing as the one before, just using the Audit C tool. You can see there are, again, are some outliers here as well. If you have any questions, you're welcome to take a look at the document. I sent a link to it there. It is also searchable on the web. Take a look for the first names of the author. I literally Googled Hannah and Staten and it came up. And you can also take a look for Monica Swan, who is one of our faculty mentors, as well as Joel Francis, who's a long-term partner now in South Africa. So,
Awesome.
any questions?
Thanks for sharing that. Anyone have any questions or comments for Catherine?
And great job to Hannah. She's currently looking for her doctoral degree. So she did this during her master's degree. She did a great job.
I have a lot of thoughts.
A lot of thoughts or a lot of questions? A lot of concern.
I'm sure in the, I think in the introduction of discussion, you guys referenced like you did, like a reference population, right? Where it's like, okay, so this is when you're comparing the papers within the review, you get one thing, but all of them are, most of them are higher than, like you said, the population average. So it makes you curious. I mean, obviously, yeah, that's the next thing is, well, why? And you have some theories for that, and they make perfect sense. One thing I wonder is about like the familiarity of these scales with the population. So you may have some kind of bias towards accuracy among the people, because if these
Towards accuracy or the other way? 'Cause I think
well,
there's a
it could
difference.
go either way. There could be a bias where there's some social desirability. But I think too, you're dealing with a population that's higher educated. They are more likely to be familiar with like the process of research such that they may believe that their data will be protected and not used against them in some way. They may not, because there's legitimate fears in certain countries for, outing a healthcare worker's like mental health diagnosis or something like that. However, so it could go either way, which is why, who knows? And it's kind of good that we've had these different tools, because someone who is familiar with like the cage, like if they use it in their practice all the time, that, not to say every time they're using it, they're thinking about themselves, but they know how to answer the question because they've, administered the questionnaire or measured it. I don't know.
I think part of the reason that healthcare workers are bad patients is because we know the questions and we know the way to get around the questions. Because I think that we are vehemently in denial and want to stay on this side of the healthcare worker relationship rather than be on that side of the relationship. And so I would be concerned that this is under-reporting of the actual truth.
Yeah,
I would love to hear from other healthcare workers that are sitting in.
I would love to hear from others, yeah, and nurses and doctors that are among us, because it's a good question, because yes, I mean, probably most alcohol use measurement is underreported. I am hypothesizing that it's actually less underreported among this population. I could be, it's just a theory. I
would love
hear
to test
your
this.
argument. I hear your
it's
contest.
dramatically more underreported
Yeah.
in this population. Because I think the risk of
I hear you.
even self-accepting,
Yeah.
because the consequences, I think is higher. So
Yeah,
I think
yeah,
that
yeah.
internalized stigma is higher. Because
Yeah,
I think our ability to reach out for mental health is worse and
right.
self-care is worse,
yeah.
all the things.
Is that universal though, across countries?
I think so, in the way
Yeah.
that
Yeah.
I can speak for physicians, because that's what my training was, but I can say the way that we were trained, self-care is taught that you are not to take care of yourself, right? You are to take care of others. And so it's the exact, I see Natan about to like shake his head.
Yeah, I would love
Computer,
to hear
he's
from
shaking his
Natan,
head so
especially
much.
somebody from the, like with a mental health perspective, but other
Natan.
providers as well. Go ahead.
Please tell us your thoughts.
Well, first of all, nurses do drink a lot, like a lot, a
We
lot.
have the evidence now.
What?
I said we have the evidence in print.
Yeah, and we just did a research. I was mentoring some students, undergrad students, and there was some participants that are my students that I know that they drink, and they're like, "Oh, I don't drink," and I was like, why you're lying?" "Oh, because I don't want people knowing that I drink because I'm a health provider." I'm like, you're a student. You're not even a provider yet.
Yeah.
Yeah, but I'll be one day, and I don't want them to know that I drink. And like, this is for every single profession. So, dietitians, nurses, everyone that we interviewed was like, no, I don't say I drink, but they do drink a lot. And like, whenever in the hospital or the primary care physicians or any unit healthcare facility, everyone drinks a lot. It's how we compensate the stress mostly because we don't want the medicine. We want alcohol. That's how it is.
It should,
And it's
Well, yeah,
easier,
what
it's
are you gonna go
available.
get something prescribed to you? I don't think so.
no, because you have to.
No,
Right, right.
yes, exactly. I don't have to report my alcohol use.
Correct.
I see on
And
it
I-
also.
And I know what like alcohol feels like. So I know I will not have a hangover because I know how to treat it. So everyone's like that. Every healthcare provider is like that. And we don't assume it. Natan's not gonna let me lie. So
Yeah,
Is that right?
and the same happens with smoking too.
Oh, for sure, for
It's very
sure.
common in the between the health providers, they smoking too, and we have the same situation. Oh, I don't smoke,
Oh.
and we
Except they're
always smoke, yeah.
Well, and you know, if you tell any provider that's treating you that you smoke, oh, here we go. Okay.
I think on the other hand, too, with the mental health, there tends to be that strong kind of push for self-care, and we always sort of teach self-care, and we
Sort of
preach self-care to students, and then kind of at the end of the day, at least in private practice, there's very much a pull to like, well, but I don't have time for self-care,
Right,
like
right.
I still need
We have
to.
to be practical here.
Do what I say, don't do what I do.
I don't know how much that's changing though. You guys think there's a shift
I think
on
it's
that?
getting
'Cause
worse.
really,
I think it's been getting worse for years.
wow.
But I also think that like interestingly, or ordinarily, I would be very much on board that I think we're underreporting in terms of mental health and other healthcare providers for alcohol use.
Yeah.
But I'd almost make the argument that during COVID, and given that a lot of us.
There was a
know
good
these
reason.
measures,
Right.
there might be a point there where some of us might over-report on measures that we know because we're familiar with the research process. To
Well-
just kind of send the message out to the public, like, yes, the building is indeed on fire.
You're on the go.
Yeah.
And I wonder if that doesn't play in some.
Interesting idea.
I would love to measure that bias and understand what direction that bias is going and how
Yeah.
it changes over time, because that's.
It would be cool to do like a cognitive interview along with these survey responses, like Natan was describing, like with someone personally, like,
Yeah.
okay, why did you put this for this question?
Yeah.
Walk me through how you made this decision, because.
You drink two, you mean two or
Uh-huh.
two? Because I just saw you drink two.
Well, yeah, and there, I've given out innumerable back depression inventories that come back to me with like a 0, and I'm like, okay, well, then I need you to explain to me what I'm doing wrong.
Yeah, can you,
Because as
are
a
you doing the
therapist,
therapy today?
Yeah, I cannot score a 0 on this measure.
Yeah. We've been talking about your depression for months, so I know you have it, so that 0 is not right.
So William says time to do PPK for healthcare professionals too, and I think that's
You're
that's
right,
kind of the
Sarah.
conclusion of this too, right? Is that we probably need this intervention, some version of it for and PPK, for those who haven't gotten hammered into them too many times, is Punguza Pobe Coafiaco, or reduce alcohol for your health intervention that we use in Tanzania. But yeah, that's the sort of the next idea, right? Is okay, what kind of intervention would be appropriate and very importantly acceptable to this patient population, provider population. You know, I could see some peer support being really useful when there is this stigma around it. To break through some of that, where you realize that it's a common problem. But there's ways to intervene.
Yeah, and there has to be something else, right? We have to like give something else, whether it's a peer support or whether it's another wellness intervention.
Because it's got to get to the underlying problem. The problem is not the drinking. The drinking is a symptom of a different problem.
Correct. Which part of it might be the culture, right? With like lack of self-care culture, we're going to reach out to something that is less beneficial. But this coping challenge that we have within our environment, we have to identify it, describe it, and change it. The PPK idea is really funny because if someone tried to do the PPK on me, I would just laugh, right? Because like we know
You
so
know
much
what,
behind-
it's
we know
like
too
watching,
much.
it's like a magician, like watching a magic trick. You're
Correct.
like, I
It's
know
like,
what you're doing.
I know what you're doing. That's not gonna work.
Yeah.
Like you could motivate me, but whatever. Like I have a different motivational system and I know what you're trying to do. So this is why we're bad patients, right? We just don't play along, we don't play the game. So we have to do it smarter for this group, and anybody who wants to do it smarter, you let me know. Maybe our AI and machine learning components are gonna make it happen. But we're just gonna have to think differently. This
Or
is gonna
maybe
be hard
it's like
to
one of those
describe.
things where like, again, because alcohol is not the root problem. Maybe the base, it's like you're getting at, maybe the unit of intervention is not about an alcohol related intervention. Maybe it is just, we need to enroll all of our providers in like counseling, like, period. Like, maybe they just need somebody to talk to. I don't know, like maybe the intervention is not centered on alcohol, but it's centered on this stress or
Yeah.
whatever's underlying, and they just need coping mechanisms or something. I don't know.
Yeah. Yeah, I heard that, and you can correct me if I'm wrong, in the mental health world, they really suggest that every mental health provider have their own counselor, right? Because you are taking on everybody else's challenge and you need to offload that to someone. Guess what? The rest of the mental health, like the rest of the medical world is the same thing. We're taking on people's challenges, whether it is bed bugs or the guy who got stabbed yesterday multiple times. And then you have to put it off to somewhere else or else it just sits in you, right? So I think we have to think differently about how to do that.
Yeah.
It is encouraged strongly, but heavily underutilized.
Yeah.
And it started to slide backwards when the APA used to require that all graduate psychology students
I was gonna
participate
mention
in
that,
counseling.
yeah.
And then they backtracked on that and they're like, well, we can't force people to participate in treatment. And we saw kind of a drop off in our students
But it's not
after that as
treatment,
well.
right? It's not really treatment.
educational
It's
to them
maintenance.
too.
It's maintenance
That's
of like life. It
That's
is
true.
like to well balance your ability to work with patients. You need to like take some stuff on and
Yeah.
offset some stuff,
I was
right?
gonna mention that, what you said, though, I don't know if that's common in other places in the world, I would assume it is, but not universal. That some, programs that train counselors require them to participate as patients. Because, I mean, first of all, for their own wellness, but it's also educational, like, to be on the other side, to have that experience, where many of them may not have had it otherwise.
Anecdotally, at least, I can say that having treated therapists, dentists, counselors,
Right.
physicians for alcohol and other substance use disorders, had by far better luck with motivational interviewing than any other approach.
It's interesting.
And
Cause they have the values underlying the behavior, I guess.
yeah, and very poor outcomes with CBT, which is interesting, because usually we're all gonna go to CBT, or most of us today are trained in
Yeah.
CBT.
Yeah.
But, with CBT, you're kind of thinking your way through the problem, and when you get into your higher IQ individuals, who think all day for a living, they tend to be able to think their way out of something and then
Absolutely,
right back
absolutely,
into it.
absolutely.
Yeah, right back
So
around.
That's a really interesting observation. Wow.
Natan.
Yeah, no, just like a thought here. The Board of Psychologists here in Brazil, they require every psychologist to have a supervisor. So a trained psychologist would be the supervisor. So they like share what they're feeling with their own patients, or they share what they're feeling in their personal life. So they don't gather everything they have inside their own and then explode someday. And the Board of Nurses, they created this program where they have like an app where you can access, I don't know the name in English. It would be like a speed counseling. Like when you need at the moment, you can do like a brief counseling just to not freak out and stuff like that. And then if you need, they'll guide you and then get you to a psychologist or a counselor that will treat you for free. So it's really interesting that they do this sometimes.
Yeah, that's a really cool approach. I don't want to miss Gabby's comment too that went in the chat about, cultural factors. Saying seeking help is stigmatized, but alcohol, most of the cases is socially accepted for coping, which is really wild. I don't know about you guys. I've kind of been absorbing that, especially like going into motherhood where there's like this like really weird cultural norm of like, oh, these kids are gonna drive me to drink, or like, mama juice and like
Yes.
stuff like that.
Yeah.
And it's like,
It's normalized.
it's like so normalized in such a like flippant way. It's wild. But then it's also stigmatized at the same time. It's like, you feel judged if you're drinking and supervising your kid, or whatever. Yeah, it's wild. And Anna, go ahead.
Yeah, I was just gonna say, I think like what you're saying about the stigma and then the coping mechanisms. I think it's interesting. Like I have several friends in Europe who are healthcare workers who experience burnout, but there the system you actually get to go on sick leave and just take a break from the stress. And when you are going on sick leave for that, insurance pays, so you still have your income and you can actually, and you're required to go to a psychologist, you're required to, have your doctor, and the doctor needs to clear you to go back to work. And then you're slowly kind of building up back to your full-time work. And if that takes months at a time, that takes months at a time, right? But I think it's, at least in the US, and it might be similar in other, low middle income countries, you don't get that luxury to actually take a break unless you lose your job, right? So you have that stress of having to stay, having to continue to perform, taking care of others. But like you may get 2 weeks off a year, right? So what are you going to do in those 2 weeks? And
Yeah.
and it makes sense then that you're moving towards like what's the like easiest way to cope, and that's self-medicating, right?
And
Whether
God
that's
forbid if you did have some like,
whether that is through like other forms of like, I don't know, ADHD medication, like whatever it is, right? Um, and I think that's where like that stigma comes in so much too, because you feel so stuck.
yeah,
And the only option away from this is if you leave the job.
which is what you're seeing, right?
Which is why so
Especially
many
during that
people are
COVID
leaving.
wave, just.
Because you're out of options, right? But if you
You're
knew
doing this
you could
anyway.
take like 2 weeks, or not 2 weeks, like 2 months, right, to just like reset and figure out what's going on and why this is so hard for you, maybe
And
you
here,
would want to come back.
even if you're in like a quote unquote supportive environment that has the resources to like maybe give you a leave of absence, that is gonna be stigmatized. People are gonna raise their eyebrows. It's like, oh, so-and-so needed a break. They couldn't hang anymore, and there's a lot of judgment and obviously problems that don't just affect that person, but everyone around. But yeah, your point about there's huge systemic factors that are driving it too. Yeah.
Yeah, you kind of feel guilty because others now have to pick up your slack, right? So like you don't feel like you get to put yourself first. Which is what Catherine was saying. I think as a healthcare worker, you're not supposed to, right? Like you take care of the patients first. You remove them out of the burning building before you save yourself. So
We actually had to teach our other attendings that they need to make sure their residents eat food. I'm sorry, eating is kind of like a natural thing, right? Like, and when I did residency, I never got lunch. I would eat before and I would eat after, and there would be nothing in between. I didn't even recognize like I should probably have sustenance, right? And so like there's this natural, you do not exist, you're there to serve others, that we kind of have to break because it's not healthy. We can't sustain.
well, and you perform lower quality work, right? I mean,
Yeah,
Not
or
wrong.
you leave,
right. Exactly.
leave or don't do well in your job. So that we don't want either of those we don't want.
But I feel like there's this mindset shift that needs to happen that like we're not able to perform well unless we're feeling well. Or are like fed, right? Like the basic, the
Fed,
basic
Water, go to
Yeah.
the bathroom when we need to,
Yeah.
Breathe fresh air.
breathe fresh air, see sunshine.
Talk to
some-
another human being that's not
That's
sick.
not a patient, yeah.
When I
It's not
hear
asking
people-
for something.
When I hear like really, let's say experienced physicians like gripe about some of the rules that they put around like the working hours of residents. Like back in my day, we could work like 100 hours a week and I'm like, yeah, did you like enjoy that? Like, was that good for you? Like, I
But there's
don't
a
know, man.
balance, right? So like, I'm a big advocate for, smarter work, not harder work, right? But at the same time, when you need to do a procedure, you have
be
to
sharp.
do a certain number of procedures to have competency, right? And so if we take our 80-hour work week where we had a ton of opportunity to see all those and do all those procedures and move it down to a 40-hour work week, you have half the number of procedures. It means the residency has to be twice as long.
Yeah, there's a balance.
So there's a balance between this where we have to understand, like, to get the competencies we need, you have to have time and active process in doing it over and over again. And so I don't want them to have 14-year residencies, but at the same time, I don't want them to have a 40-hour work week and never see what they need to be competent. So there has to be a balance between the two.
Well, it's been a wonderful discussion. Any last final thoughts? Hope we haven't driven anyone to drink. Just,
Or to not go into being a doctor or a coworker.
oh, yeah. For sure. Mission accomplished, yeah.
I don't drink. We're good.
Sure you don't.
Yeah.
I was like, excuse me. I know what it was. No, I'm just kidding. Okay, well, thanks everybody for the great discussion. So yeah, in the top there of the Zoom, you had it. We'll stop the live stream. Yeah. And we'll